So, thank you for that. And I think we are going to say basically the same things. I love that you started with a philosophical discussion of Rob Califf, let's do good things, making people think, oh my God, he's going somewhere really great with aspirin. And so I'm here to say that today's the day, and these are the days that we have to say that less is more. And less is more for many of our patients. And you might say you want to save money because you're going to give them a cheap therapy, but that cheap therapy, if it's aspirin, it could be hurting our patients. And we are seeing that over and over again. 20 plus years ago, we saw that in the trial of the Capri trial, clopidogrel was superior to aspirin. That was 20 years ago, and we revisited that this year at the HOST MI. I'm not even going to talk about my study, but the study of the HOST MI, where a HOST exam study in Korea in 2021, ACC, hot off the press, just a month ago, where 5,000 patients in Korea were randomized after a certain period of dual antiplatelet therapy, 6 to 12 months. If they were event-free, they came in and they got aspirin versus clopidogrel. They were followed for a year plus, and they found less bleeding with clopidogrel and less clinical events, even in the same arena. And to me, that's a superior benefit of getting away from aspirin. And why is that? Because we have gotten so much better in our medical management of our patients. In the past, when we saw that incredible benefit of aspirin for secondary prevention, when you saw the antithrombotic trialists where there was a huge benefit in reducing stroke, MI with aspirin, it was fantastic to see. And that was based on the fact that the background therapy in our patients was very small. In fact, they didn't have PCSK9 inhibitors. They didn't even have statins back then. And so now we have treated the risk profile of our patients with these wonderful drugs, such that the absolute reduction of events by aspirin, that absolute risk reduction is now minimized, and it's no longer showing that kind of effect overall. And we also have now better novel antiplatelet agents like ticagrelor and prasugrel. And in presence of those potent agents, aspirin is doing nothing but sloughing the GI tract and causing GI bleeding and other types of bleedings. These have been very well described. And in the past 2 years, we have seen over and over again data now switching, instead of going to aspirin monotherapy after a period of DAPT, to P2Y12 monotherapy, even with clopidogrel monotherapy in trials like Stop DAPT, which was in Korea, 3,000 patients, 3 different stent platform. And they showed in the SMART DAPT study where there was absolutely no difference in the ischemic events and a huge reduction in bleeding with clopidogrel monotherapy versus DAPT. When we looked at the Stop DAPT investigators with the Science platform, after a 1 month of dual antiplatelet therapy compared to 12 months, 1 month of dual antiplatelet therapy going to clopidogrel monotherapy, showing exactly the same results. A reduction in NACE, but all driven by reducing bleeding complications. In Twilight, you saw reduction in bleeding complications going to ticagrelor monotherapy after 3 months of DAPT compared to 12 months. Absolutely no difference in the ischemic events. And when you go to TICO, I just gave you 5 studies, TICO study that had STEMI and non-STEMI patients, there was a reduction in bleeding without change in ischemic events again. And when there was a meta-analysis by Michelle O'Donoghue in Circulation in all these 5 trials showing that P2Y12 monotherapy is beneficial in reducing bleeding after ACS and PCI. They looked at both of those parameters without increasing ischemic harm. And in fact, the ischemic events were lower with P2Y12 monotherapy compared to DAPT. So there's no question that that is the way to go, that we need to go into a place where we are now thinking of a more novel strategies for our patients. Now, the flip side of the coin is the COMPASS trial, where there was an aspirin-free arm with rivaroxaban at 5 milligrams versus alone, versus rivaroxaban 2.5 milligrams plus aspirin versus aspirin. And of course, that there, it was the Riva plus aspirin arm that actually was the most beneficial one of all. And so you might say that it's not like we're burying aspirin, but I'm just saying that we're probably retiring aspirin. And retirement is actually a good thing for these old drugs, that perhaps it gives us an ability to think about some novel strategies moving forward. And that's my debate.
As well done without any slides. Fantastic. The only one point I would make, which I think is the fundamental question with all antiplatelets, antithrombotics. Do we believe there are drugs that can keep you from clotting and make you bleed less? That seems unlikely. So if you have stronger agents, you're always making a trade-off. And we just have to make that decision of what that trade-off is. I think the second thing is in all the more recent DAPT, because I showed Capri and Charisma, because before stenting, really before clopidine and clopidogrel, before stenting got to DAPT, there's no indication for DAPT until ACS and stenting gets there.
Yeah,
all the dropping ones have to have it on for a month or 3 months.
I agree with you 100%, but remember one thing. There are patients where we want to give them a potent agent for a longer period of time. Those are the acute coronary syndrome patients and STEMI patients. And we know that we are, by giving them dual therapy with aspirin plus ticagrelor, which is currently a class 1 indication for those patients in the European guidelines, 2A in the US guidelines, we're having a lot of issues with bleeding. We see that exactly. So if you want to give them the potent agent for a longer period of time, take the aspirin off. And that's what the 2A recommendation in ESC for ACS patients are. In select patients, given that benefit, you can allow a longer period of treatment with a potent agent that's going to be helpful in that very high plaque burden patient, and keep them away from the bleeding episodes with GI tract bleeding, et cetera. And I think that's the kind of thing, the novel strategies that are coming forth, switching it off, going to clopidogrel, de-escalating, maybe using platelet function testing. And we certainly know that in AFib and PCI, get that aspirin off as fast as you can, because you absolutely will be saving a lot of bleeding complications. So I think I won the debate since I'm moderating, but no. Thank you so much. I think we both are saying the exact same thing. And